Assalamu alaikum. Starting the clinical day, Mr. David, 55 years, with complaint of fainting. Ready to start?
Yes.
Dr. Aisha? Okay.
Yeah.
Waiting for timer.
Okay.
Here you go.
Okay. Hello. I am Dr. Mitwali, the doctor in clinic today. May I confirm you are Mr. David, 55 years?
Yes, I am.
Okay. Welcome, Mr. David. I am here today to discuss with you your medical condition, and may I need to examine you. Is this okay with you? Okay.
Sure, doctor.
How do you feel, Mr. David?
I'm not feeling well, doctor. I'm so worried.
It came to my knowledge that you fainted. Can you tell me more about that?
Yeah, doctor. Actually, I faint like 3 times till now, and I'm worried about them. Every time I lost my awareness, and then I awake up without any alarming. I don't know what's ongoing, doctor.
I'm sorry for that, Mr. David. I know how this is bothering, and I'll try too much to help you today. Okay. And I'll answer your concern at the end of our meeting. Is this okay?
Yeah, sure, doctor.
Okay, so what is the last time you faint, Mr. David?
Yesterday, doctor.
Okay, and the 2 times before you said that this is 3 times. Can you tell me
Yeah.
the time of each episode?
Yeah, the last week and first time 2 weeks back.
Okay, anything is you doing at this time? You faint every time?
And every time I was doing something different. One time I was sitting, eating the food. One time I was even lying down in the bed. And one time was I was walking.
Okay.
That's it, doctor, yes.
There's any feeling you notice before you fall down? You mean by
Yeah.
fainting you lost your conscious completely?
Yeah, I
You're
feel,
unaware.
yeah.
Yeah.
Yes,
Okay.
unaware, and I feel like blackout, doctor.
Okay, Mr. David. So anything you feel before this episode start before fainting directly?
No, doctor, just blackout.
So you feel dizzy before
Mm-hmm.
and you feel that unable to see for a moment?
Blackout, then yes,
Yeah.
I lost the awareness.
Any strange smell, any strange
No.
voices? Okay. Do you feel any heart racing, sweating?
Yeah, doctor, you're right. Sometimes I feel not racing. It's like low, not racing. It's very slow.
Like, yes, like feeling awareness of your heartbeat.
Yeah.
Uh-huh. And sweating?
No, doctor.
Okay. And at this time you faint, Mr. Ravi, anyone was beside you with this fainting?
Yes, my partner, my wife, she was beside me, and she gave me later a cup of juice, but it's not helping, doctor. I'm still feeling drowsy after that.
How many minutes you staying unaware?
Yeah, like 1 or 2 minutes. Then I felt okay. Like
And
when I
you
lie
regain,
down.
yeah, okay. And you regain your conscious completely by
Yes.
after 2 minutes.
Yeah.
Yes, so spontaneously, yeah.
Mhm.
Okay, yes. And anyone you like felt down to the ground?
The time I was walking, I fell down.
So yesterday, what you do before?
One time was eating, sitting.
Yes, yesterday one, what you did before fainting?
I was lying on the bed.
Okay. And during these 2 minutes, is your wife noticed any shaky movement?
No,
Okay. Is she noticed any rolling to your eye?
no.
Okay, sorry
She didn't
asking
tell me
you
that.
this. Uh, uh. Sorry asking you this question, but it will help me.
Uh-huh.
Do you any time you wet yourself during this
No,
attack? Any time you bite your tongue?
no.
Okay. And after this attack, Mr. David, you said that you regained the conscious. You feel any
Mhm.
dizzy? You feel any weak?
Yeah, if I'm not lying on the bed, I feel
Yeah.
dizzy. But when I
And
lie
you
down,
feel,
I feel
yeah.
okay.
And you feel like weak or not okay after
No, no,
this?
I feel
Uh,
everything is okay after that. But apart from the dizziness, yes, I'm feeling
uh,
okay.
okay. What do you try after this attack to help you, like lying other than
Yeah,
lying
just
on bed?
rest. Yeah, lying on
Yeah.
the bed and rest.
Okay. Anyone measure your blood pressure at this attack? Blood pressure or blood sugar?
No, doctor, I didn't.
Okay. You didn't seek any consultation about this before.
No, first time.
Okay. Okay. Do you have any past history I should be aware, like any disease you are diagnosed with?
Yeah, doctor, I am having high blood sugar, high blood pressure,
Yeah. This
and
for how long?
for 20 years now.
Okay. Any other thing?
Mhm.
Uh,
I have
what
a problem in my heart.
uh, what is problem?
Yeah, I had heart attack before,
Uh-huh.
almost 3 months now.
3 months. And
Yeah,
what happened during this heart attack in hospital?
yeah,
What they did for you?
they did for me stenting, something like that, and after
Uh,
that, they told me my heart beats very low, and they shift me again to a room, and they put for me some machine.
so you are now on machine for regulate
Yeah.
your heartbeat. Yeah.
Yes.
And do you notice any thing happen to the machine, like you uh, have any trauma on forehead?
No, doctor. Maybe I'm going to the gym, but no trauma, doctor.
And you check it recently?
No, doctor. To be honest.
Uh, what as last time of your follow-up with cardiac doctor?
Yeah, it was 2 months back.
Uh, okay, okay. And any other past history I should be aware of?
No, doctor.
Can you show me your medication?
Yes, patient on captopril
Mm,
and on amlodipine
mm,
and beta blocker,
okay.
and also
During
thiazide.
any aspirin? No. Okay. So the last 2 weeks when started this fainting, Mr. David, anything you have different in your life, like any flu, any bug in your
No,
throat? Okay, any cough,
no,
any travel,
no.
any strenuous exercise or anything you did from
Yeah,
these
doctor.
past 2 weeks? Yeah.
I'm going to the gym, doctor. I have exercise training in the gym. I'm doing, yes, I'm lifting some objects there.
Uh-huh. Okay. Okay, Mr. David. And do you have any surgery in the past?
Yeah, doctor. I had trauma, maybe not surgery, but I was reviewed by the bone doctor, and they
Mhm.
did for me some images, and they told me no need for surgery because I fell
Okay.
down on my
What
my
time? Uh,
yes, the last 3 weeks back
fall down on?
in the training in the gym on my hip.
Uh-huh. I'm sorry for that. So at this time, you found that no problem at the scan, and they just give you medication and left.
Yes, they give me
Uh-huh.
some medication and they told me to take rest. That's why I'm
Okay.
resting at home.
Okay. Okay. Okay, apart from this cardiac problem and hypertension diabetes, any other problem you have in the past?
No,
Okay. Do you have any high temperature,
no,
any weight changes,
no,
any lump you notice in your body?
no,
Do you have any breathing difficulties?
no.
Um, do you find that you can't sleep on the normal pillow for you or gasping air at night?
Actually, doctor, yes, I am sleeping on three pillows.
This is for how long?
Also for the last month.
Okay. And any like swelling in your limbs?
Yeah, sometimes I feel, especially if the legs are down.
Any chest pain?
Um, no, doctor, I'm not having
Mhm. And you, at this attack, you feel like awareness of your heartbeat. Any other time
no,
you feel this awareness of your heartbeat?
no, doctor. This attacks only.
Okay. Okay. And any time you feel dizzy, apart from this attack, for standing, from sitting
Yeah,
to stand? Ah, you feel
yes,
like that?
sometimes. Yes.
Yeah. Okay. Okay. Do you feel any headache?
No,
Okay. Any weakness anywhere in your body?
no,
Any visual problem or eye problem?
no.
Okay. May I examine you?
Sure, doctor. Yes.
Okay. I need to see the vital sign, vital chart.
Yeah, 130 sitting, 130 over 80.
Mm.
After standing, 110 over 60.
Okay. And the pulse
50.
on both sides and
Yes.
regular, regular.
Yes, regular 50.
Okay. Then I'll see the jugular vein. It's tender.
Yes, you can feel also cannon wave.
Canon. Okay. And I'll then auscultate the heart. I'll start by apex. Any irregularity in murmur field?
No.
Here? No. Okay. I'll then auscultate the back of chest for
Uh-huh.
any crepitation, lower
There is a
crepitation.
yes,
There is
fine crackles,
fine
yes.
crackles. Okay. And I'll then check for the machine that he put.
Yes, there is a
Uh,
scar. You can notice there. You can feel
any
the
ecchymosis beside the machine?
no,
Anything? Any bleeding around? No.
no, no hematoma.
Okay. Okay. I'll then check the lower limb for pedal pulse
Hmm.
present.
Weak.
Weak. And the edema. There is edema.
There
Uh,
is
okay. Okay. After that, I'll check. There is no high temperature, so no
no
high
high
temperature.
temperature, normal.
Okay, I'll check also for neck rigidity. No, no any pain in your
No,
neck.
no.
Okay, okay. Then I'll ask him to raise the hand, and if he can raise both hands steady, no
Yes,
weakness,
no
and also
weakness.
raise the legs, both legs. He
Yes, he
can.
can. Yes.
Okay, okay. What you do for living, Mr. David?
I'm retired now, doctor. I'm just going to the gym for uh,
Okay.
yeah, enjoying
Do you
my
need
time.
any support or
2 minutes remaining.
any financial struggle or you need any support?
No, I'm fine, doctor, so far.
Okay, and your wife living with you is this supporting you
Yes,
and
she
can help
is.
you?
Yeah, she's
Yeah.
helping me, doctor, whenever I need.
Okay. Are you smoke, Mr. David?
Yes, doctor.
How many for how long?
Only 5 cigarettes.
Okay. I really also advise to stop smoking because it really hazard for your life and especially in your situation.
Uh-huh. Okay, doctor.
Okay. What is your concern, Mr. David?
What I have, doctor? Why I feel fainting a lot of time now?
Most probably the condition you have, Mr. David, from talking with you and examining you, you have problem in your heartbeat, and most it is the cause mostly is that this machine for heart regulation is not working. Maybe because trauma, maybe any other thing in the battery, but we need to check it urgently right now, and I need to admit you to check this machine and check your heart probably with the heart doctor. Any other concern?
No, doctor, thank you. So
Are
you
you
will admit
drive?
me?
Yes, I'll
Yes,
admit you right
I
now.
came with my car, doctor.
I really advise you to stop driving because it is really will harm you and the others because you have an unexpected fainting and it can happen anytime. So you can stop now and please inform the DVLA about your condition.
Okay, doctor.
Okay. Any other concern, Mr. David?
No,
No.
doctor, thank you.
Can I check the blood sugar?
Yeah, blood sugar, okay.
Okay.
Okay,
Okay.
thumbs up. Perfect.
Okay.
Let's go to the examiner questions. What your case about and the differential?
Okay, this patient is 55 years, presented by fainting, 3 episodes. It is like cardiac syncope. He has a recent MI 3 months ago that complicated by, I think, AV block, and he has for that pacemaker or has I think pacemaker.
Excellent.
Uh, he uh, uh, he during the attack he lost conscious for 2 minutes and he fully awake after it. He feel dizzy and blackout before the attack, and he has aware palpitation and bradycardia. He is on multiple medication. Um, uh, I forgot to say, ask if he compliant with, but I
Excellent.
think he has recent trauma
Yes,
3 weeks
excellent. Okay.
ago.
What's your differential?
Most probably this patient has the main condition that heart failure with heart block, and this is the main problem after MI, but it is must be corrected by the pacemaker, and I think the pacemaker not working right
Okay.
now for him. Yeah. So he has like
Okay. What do you think the reason
cardiac syncope. Eh?
could be? What could be the reason for non-functioning pacemaker in his condition?
Maybe the trauma he has
Excellent.
in the gym.
So
Uh,
what can lead to the trauma?
Dislodge of the electrodes from the ventricles
Either fracture or
or
dislodgement, right?
fracture or fracture of the
Yes.
machine itself or the battery
Fracture of the
dislodge
wire
also.
or the dislodgement.
Yes, yes,
Okay. Okay. This patient had trauma to his hip, and he told you he did some image. Did you
yeah,
ask what the
yeah.
image was?
It
What the
can be
importance?
MRI.
Yes, perfect.
Yes, it can be MRI and it can affect also the machine. Yes.
Excellent. Yes. So give me now differential.
So the differential of not working properly the pacemaker, maybe the trauma, maybe the MRI he did.
Excellent.
Uh, maybe also we will consider different MI or different ischemic attacks
Okay. One more.
if he not compliant to medication. One more, it can be TIA. I don't
Remember,
know.
always if you have medication, it might be the reason. Okay.
There
Whenever
is
you have patient on medication, it might be.
okay.
Yes.
Yes, maybe postural hypotension.
Excellent. Excellent. Okay.
Yeah.
Tell me now how to investigate this patient.
This patient, I'll admit him. Firstly, I'll do for him ECG
Mhm,
and I'll do bedside echo.
mhm,
I'll inform about the machine to
mhm.
checked by the, I don't know the responsible, but
Programmer.
maybe the
Programmer.
programmer. Okay, yeah.
Yes. Excellent.
And this patient, I'll start him on outside pacemaker, like just or portable pacemaker till full
Trans-
diagnosed.
Transcutaneous or transvenous. Yes.
Transcutaneous, yes.
Okay.
And then we will run basic investigation for him. That
What
full
the
blood count.
important? Yes.
Uh,
What the important of blood count in this patient?
this patient on antiplatelet therapy. He is also he can and has trauma recently, so I need also to check if he has bleeding anywhere
So what you are looking in
anemia.
the CBC? Yes, anemia,
Anemia.
exactly.
Yes,
So
anemia.
yes, anemia can also present with the same, right?
Yes,
Patient will
yes,
come with
that's
visceral
right.
hypertension. Okay.
Mm.
This is the fourth differential. One more, sorry,
Mm.
what other investigation?
I'll do also CT brain to
Mm,
exclude any bleeding or any thing because of trauma,
since since
recurrent trauma.
since no lateralization, no need. Unless he has head trauma. Did
Uh,
you ask him he had trauma
he said that
specifically?
one time
He fell
hit the
down.
ground. Hit the
Yeah.
ground. Yeah.
Did you ask, did you hit your head?
Yeah. No, no, I didn't
Okay.
ask.
So
Okay.
don't put unnecessary image. Okay.
Okay.
What the image important here to do?
The image here is it's the echo or you need is image for the heart. Yeah.
Chest X-ray,
Image. Just okay.
right?
Just
Chest
X-ray.
X-ray. At least it will show you fracture. It will show you dislodgement, the position,
Pulmonary edema. Yeah. If
plus
he is
the
acute
complication.
heart
But
failure.
it will
Yeah.
show you also the position of the wire and
Maybe. Yes. Yes.
if fractured
You are
wire.
right. Yes. Very,
Okay.
very important. Yes. Yes.
Okay. And how to manage this patient?
We will start to him on percutaneous pacemaker, and maybe he need to increase the dose of diuretics for heart
Increase
failure.
or to adjust accordingly. You
Maybe
don't know.
adjust.
He has
Yes,
also, yes, he
in
might
heart
have
failure. Yeah, yes.
dehydration, visceral hypertension. I don't know his volume state.
Okay, I'll
And
adjust.
yeah, and he might be
Okay.
in the failure because of the failure of the pacemaker.
Or the diuretic itself.
So
Yeah,
the
okay.
best answer here, not to start by pacemaker or whatever. What the best answer here you think to start with?
Okay, non-pharmacological and
And
pharmacological.
before non-pharmacological.
Admit
Admit,
and
accept, and
ABC.
okay, if
يعني
yes, if patient hypotensive, yes,
yes.
rehydrate or resuscitate or whatever. Okay, and
Yes.
you will
Uh,
manage this patient by yourself?
no, I'll include the
Ex-
cardiology and
Yes, multidisciplinary team
matter.
approach.
Okay, yeah.
Even in this team, you will call them programmer to
Yes,
check the
and
machine.
specialized.
Yeah.
Uh,
Okay,
yeah, okay.
and echo, cardiology, even
And
diabetology. You
intervention
don't
cardio,
interventional
yes. Yeah,
radiology. Even
yeah.
diabetology, you don't know patient is controlled or no. Maybe also
Diabetic,
he
yeah.
has
Yes,
diabetic
endocrinologist,
complication,
yes.
autonomic neuropathy. But it's a complex case to ask all these details. Anyway, at least remember them in the management. Okay, the good thing also you advise regarding driving,
Mm,
because even he's sitting or even lying down, it's coming, the fainting, right?
yes.
Because it's related to the malfunction of the pacemaker. Okay, I think you did the
Mm,
case, Dr. Aisha. Well done.
thank you, doctor.
You reached to the diagnosis. Even you ask a good question regarding the possibility of complication like PE, travel, and but whenever you have something positive, ask more about like to fall down. Ask for what you hit. Is it your head? It might be
Mm,
also hemorrhage, subarachnoid, or
yes.
subdural due to chronic falls. It might be
I think
uh,
for this patient, we should do CT brain, even if no
no,
lateralization, because it is like, if subdural, it be like slowly progressive.
no,
Maybe
but
if the CBC show anemia, I
exactly,
think. If the CBC show anemia, okay. Because
especially
he is on the anticoagulant and has trauma.
Dr.
Uh,
Aisha,
uh,
clinically, patient is diagnosed, right? He
yeah.
has good positive history, diagnostic history, pathognomonic history. Patient had lift up heavy object. He went to the MRI. If you do
Mm,
all these steps and no
mm.
explanation, you can do CT
You
brain. But
can,
yeah,
yes,
but CT brain
explain it faster.
immediately,
Yes.
yes, it will not, because if in even the examination you don't have any lateralization. If in subdural or you said subdural or epidural. Epidural rapidly collecting, it will not be for this duration. Subdural will be the one, but also it might have symptoms, neurological symptoms. Any
Yes, if I ask about hitting the head, it will be better. If he has any commosis in head,
yes,
it will be a guiding. If
exactly.
no, it is will be anemia.
No
Okay.
need, exactly. Yes, yeah, I agree. Yes. Okay.
Okay.
This is the point here. Also, the history about the beats, slow beats, and feeling that happen while he's sitting, while lying down, it's not related. So mostly something related not to the heart itself as palpitation. No, it's something related to if you took the history more, as you did, you will find the history as in this case. Patient had heart MI complicated by complete heart block, and he underwent the pacemaker. Then he fell down and he did MRI, the battery maybe, or the battery, yes, because of the MRI magnetic field, the battery is not working anymore. That's why after that he had the attacks again and again. The other thing you put in your mind, the dislodgement or fracture due to lifting the objects or heavy object, and any trauma also to the chest might also lead to fracture. These are the possible differential in this case. So malfunctioning of the pacemaker due to the battery and MRI incompetency, and incompatibility, I mean, not compatible with the MRI. And the second differential, the fracture of the wire, dislodgement of the wire. The third differential, posterior hypotension, and you should ask the question for the medication. Are you compliant? Did you increase? Did you add? You have to ask because it might be at the end posterior hypotension. This patient is for differential. The last one, anemia. If you rule out anemia in the examination, you will be in the good track. But if you didn't, you have to ask it in the history. Anyone told you you are paler than before, and so on. So anemia is still one of the differential. It might be the cause of syncope or fainting attacks. Okay, these are the differential and the case. I think the case now clear, and you did great, Dr. Aisha. Any question? Any comment from
Thank you,
others?
Dr. Beth. Thank you for
Yeah.
that.
Yeah, she did well, really. Had Dr. Hadil comment, she did well, yes, I agree. Maybe
Thank you,
has
Dr. Beth.
ICD. If she asked me clear question, and also I told her
بصك مرشفة
my
عليك
heart,
ما
my
قالوا
heart,
كانت خارجة.
my heart, sorry, by mistake maybe. If she asked me what exactly happened during the heart attack, I told her already the heart rate was low, and they took me to the machine and or the room. They put me in battery, so it's clear like a pacemaker. ICD, if sustained VTAC, this is the indication for ICD as we know. Sustained VTAC, they will put ICD or
Because
ICD with
yeah,
HOCM.
I think he told he has heart attack,
Okay.
so it may
Yes.
be like
Yes,
VF
you're
or
right. VVF, VTAC, it might be, yes. But he said his heart rate was low. That's why they took him to the room and they inserted machine. In the other way, or ICD, I mean, he will tell, for example, I had some racing of the heart and they put me on another machine. The other indication also for ICD will be HOCM, right?
yes.
Yeah. But in this case, complete heart block, post MI, and pacemaker insertion.
Yeah, I think if we are in doubt, we can ask directly, does this device give you
Yes,
any electrical shock, or
yes,
did you feel any electrical shock? Yeah.
exactly. We can ask this question.
Yes.
And also for the dysfunction of the ICD, the patient will have palpitation, not slow heart rate. And here in the malfunction of pacemaker, the patient will be in block. That's why he's feeling heartbeat or heartbeat are slow. But in the ICD failure, it will be the opposite. Patient will have racing of his heart rate, right?
Yes, but both of them can lead to syncope.
I agree, but I mean the difference between both. The syncope can happen with VF, VTAC. Yes, I agree. It might happen with heart block and bradycardia. Yeah, but how he present with, he will tell you, I feel the heart rate or very fast or very slow. And in this scenario, I told her I have very slow heart rate, and she
Yes,
found
yes.
in the examination her heart rate was 50. So it's seems to be a pacemaker rather than to be ICD. But you're right, VTAC also can lead to, and VTAC can complicate also the MI. Okay, ICD also might come with the HOCM, as I said. It will be scenario with the HOCM and patient admitted or inserted ICD for him, and maybe the same issue happened, and he feels syncope. So the palpitation happen or VTAC happen, arrhythmia happen, and he has these attacks. Okay.
Dr. Basim,
Yes.
can we added subdural hematoma as a second opinion differentiate this patient? Because in spite
I
of
agree.
all history
Yes.
clear with a cardiac attack, but
Yes.
as elderly patient with a
No, he's not
decreasing level
elderly.
of consciousness
He's
and history
55.
of trauma. Yes.
Okay. Let's talk about subdural and paces. How it comes. It will be with elderly. Elderly means the 70 plus and it will be with alcoholic patient drinking alcohol with multiple falls on aspirin or warfarin or whatever, any anticoagulant, and head trauma frequently. In this scenario, he didn't mention at all any head trauma. He fell down, but he didn't injure his head. If she asked me, did you hit your head? I will say no. So please, whenever you have positive point or positive finding, analyze it more. Is it hitting to the
Yes,
head?
I know. A clear, there is clear history of cardiac attack.
Yes,
But
I can't
I
put
mean a second
subdural.
opinion.
I agree if he has like the, for example, any weakness, he should be in weakness, right?
Yes, yes.
He should have weakness, numbness, because
It's no
subdural,
neurological deficit. Yes.
exactly. But if no, she asked me about CNS, and this is good also by Dr. Aisha. The only point missed by Dr. Aisha in this is the diabetes, and even one question for diabetes might help her to roll out diabetes, like hemoglobin A1C, for example.
وانت صحيح ما قلتليش اي medication
Hypoglycemic attack.
للدايابيتس في الحالة
Yes,
دي.
yes, you're right. I focus on the cardiac medication and the
أنا
hypertension
كمان أيوة.
medication.
But
Yes,
really
but
it is low time, so I have no
okay.
time to.
Yeah, I brought this case, and the previous case, it was also complicated one. We don't know what we'll face in the exam. They might give us complex case, hypertension, hypothyroidism, a lot of comorbidity, and you have to pick up the positive finding and to reach to differential, accepted differential. Like this scenario,
And don't
yes,
miss the important point to
exactly.
finish the skill.
Yes, and
It is the
also
important point here for me to be social support and driving.
exactly, and you did it. Driving, welfare, these things very important to mention to the patient before the examiner, because he
Mm.
will comment on that.
So,
But
what is the other differential for this patient? If the examiner asks you what is the other differential diagnosis?
I mentioned four. I mentioned the malfunctioning of the battery of the pacemaker, of course. I mentioned dislodgement, fracture of the wire. This is if you consider both as one. Okay, so this is the second differential. The third differential will be posture hypotension due to the medication. He's on diuretics. You don't know if he's increasing the dose or whatever. Even you might put in the differential. He might increase the dose. He might decrease oral intake. He's not taking good orally. And the last one, and you can put it in any syncope, the anemia, especially with posture hypotension. This patient was having positive finding in posture hypotension, right? When you check the blood pressure sitting and standing, there was.
Yes.
So still you can put anemia but you have to examine for anemia signs at least once, or the pallor in the hand, pallor in the eye, or by one question. If you don't have time to examine the anemia, you can ask also for anyone told you are dizzy, paler than before, or you feel dizzy while standing from sitting. But this is also not a specific question for anemia. It's a question for positional hypotension. Okay.
Okay, thank you.
Thank you too. But neurological, don't put it, especially no lateralization. And the scenario will be drive through the neurological symptoms and signs. It will not be
Because the
cardiac.
question of examiner unexpected. Anything can ask you any
No,
question.
I don't think so. Examiners always ask about the differential and the related differential. If you put it here, neurology cause, it will be against you because nothing
Yes.
with the neurology here. Even if he asks you what else, we have 5 now. We put 5 differential. As Dr. Aisha mentioned, he might have ischemic heart disease again, MI,
Yes.
or unstable
Yes.
angina. Yes, arrhythmias. So anything related to the heart, still you can put it in the differential. But I can't say this is, for example, epilepsy. No any signs for epilepsy in this patient. No, I can't say also hypoglycemia. She asked me any shaking, any hunger pain. And you can add also question to the history taking. Anyone check your blood sugar, as you ask anyone check your blood pressure, to be sure that it's not hypoglycemia. Okay, and also sweating, it was ruling out the hypoglycemia. I told you no sweating. You can put one differential on this patient, autonomic neuropathy. No one can blame you because the patient is diabetic and he might be uncontrolled or poorly controlled diabetes. But again, no neurology, no hypoglycemia. The first thing is cardiac, then cardiac, then cardiac. Okay?
Okay, thank you. Thank you for that.
Thank you too. Okay, Dr. Aisha, you can write your scenario. I hope you will give me a complex case like this.
Okay.
Okay, what is the management for, question by Dr. Sarah, what's the management for this patient before readjustment of the pacemaker? Yes, acute state, always start with the acute. Patient came to you in heart block. Definitely you'll admit him, right? ABCD approach. If he's dehydrated or heart failure or whatever, according to the status. If after finish resuscitation or assessment, now you call for the multidisciplinary team, including the cardiologist, echo technician, and the programmer to check the battery, and radiology intervention. He might need reinsertion, readjustment, or whatever. ECG, of course, you have to do, and chest X-ray, and baseline basic investigation, CBC for anemia and any infection. Of course, you can rule out also infection in this patient because he has foreign body. Still, it's a foreign body, the pacemaker, so it might be infected. However, I deny any signs of fever or signs of sepsis. Okay, then treat the cause. What the cause here? The wire dislodge. Okay, reinsert, fracture, change. A battery, adjust the battery. Posture, hypotension, and medication. So review the medication, and adjust his medication according to the volume state. This is the management plan in this patient. But don't start saying, I will put pacemaker. That's it. You have to look to the patient from all direction, not only the pacemaker as a pacemaker. Still, you have to check for the vitals, for the ABCD, I mean. Maybe he's hypotensive, needs rehydration. And after that, even you want to insert pacemaker, Dr. Aisha, this is for you. Tell him multidisciplinary team because you are not the one inserting the pacemaker. I will call the cardiology to check along with programmer
technician.
still,
Yeah.
it's not my job. Always they like to mention the multidisciplinary team, not even if you start to say that, he will ask you, doctor, you will manage this patient alone, and you'll be in trouble. So anticipate that. Don't wait for him to tell you, are you managing this patient alone? It will not harm you if you say this sentence. I will start by multidisciplinary team approach. Okay. Long case and communication. Thank you, Dr. Aisha. I will start. Give me 2 minutes. No, it's long case.
Very
Mr.
bad.
Yeah, Mr. Hamid, 65 years, complaining of abnormal gait, recurrent fall for the last 6 weeks. He is known case of hypertension. First time I see the abbreviation HNT on amyloid, 10 milligram for your kind care. Senior. Yes, I know. Senior health officer of neurology clinic. So you specify the clinic now. Neurology clinic.
Yes.
Discuss the issue with Mr. Hamid. Okay. Just 1 minute. Okay, we can start.
Okay.
Hello, I'm Dr. Mukhtar, the doctor in the nerve clinic today. You must be Mr. Hamid.
I am Ahmed.
Ahmed? Okay, sorry
Son
for
of
this. Okay, Mr. Ahmed, you are 65 years.
I am son of the person, the son. You will talk to the son.
Sorry, I didn't. Yeah, his son, Hamid and Mr. Ahmed.
Ahmed.
Yes, was Blair.
Start
Okay.
again بقى.
Yes, we will start again.
Okay.
Sorry for this. Okay.
No.
Hello, I'm Dr. Mukhtar, the doctor in the nerve clinic today. You must be Mr. Ahmed.
Yes, I am doctor.
You are the son for Mr. Hamid.
Yes.
He is 65 years.
Yes, doctor. Yes.
You are the next of kin for him.
Yes. I am coming with him now, and I'll try to explain instead of him because he feels that like not good enough to speak to you.
Okay, I'm so sorry about his suffer, Mr. Ahmed. Be sure that we will try our best to help him. Can I ask
It will
you
be good, doctor.
Yeah, thank you. I will ask you some questions, please. Then I will examine Mr. Hamid. Okay.
Yes, doctor. Yes, sure.
Okay. And can you tell me more about his problem, medical issue?
Really, doctor, we are all surprised at home. Just it is like short time. We found that is gradually increasing, and it is like rapid increasing. First time we suspected that he is like he didn't eat good, so he fall down frequently. He can't maintain his balance. We all again and again realized that too, that he didn't eat good. But unfortunately, the last 2 weeks, this is increasing a lot, and now he can't walk without help. We should be beside him all the time.
I'm so sorry about his suffer, Mr. Ahmed. So you think it's progressively worse?
Yes, exactly.
Okay, and this is started by normal gait. He can't walk well, right?
Yes, it is like we see him that like he like can't walk or that like swinging sometime.
Okay. Apart from his gait, any other problem started with the fall?
Really,
The
doctor,
frequent
it
fall?
is all together. Yes. Um, I don't know. It is because he like shying from us, but he look nervous than usual. He also ask us to leave him alone more time. Uh, we notice that he has some changes also that he before doctor this 6 week he has supermarket and he manage him alone and he can make all the things and he manage all things. We didn't follow him and we surprised that the last weeks that some things goes wrong and someone tell us about that he mistakenly in the accounting and some things and he lost a lot of things because that we have market loss this weeks.
Yeah. So he has some memory loss.
We don't know exactly, doctor. I think he has like he can't concentrate good.
Okay.
Yeah, like
Any
that.
any problem in his balance?
Yes, exactly, doctor. He can't keep walking good now. He like walking on the boat.
Okay. And apart from this, any problem with the weakness? He has any weakness in the power, I mean?
I think no, doctor.
Okay, any problem, sorry for this question, about the control of his water work?
Yes, doctor, you're right. This is appear also recently that he have urge. I think he can't reach the bathroom for his water work, and he withheld himself frequently these days.
Okay, I'm so sorry about that. Okay, apart from this, any problem with the speech
No, doctor. No,
and the hearing?
no,
Okay, and any vision problem?
no,
He had headache earlier or before that, this attack.
no. He didn't tell us about any headache he had.
He feel any neck stiffness,
No, I didn't think that.
any high body temperature,
No,
any loss of appetite,
maybe, doctor. Yes.
any night sweats?
No,
Okay, any lumps or bumps in his body?
no. We didn't notice that.
Okay. Apart from this, any problem with the sleep?
No, no,
Any
nothing at sleep.
okay, in any changes in his behavior? He become like aggressive with you?
Yes. I told you, doctor. Yes, we think he is different from before.
Okay, any tremors or shakings of his hands or legs?
No, nothing we notice it.
Okay. Apart from this, you told me he's vegetarian or he's not eating well?
Not vegetarian. He just this time also that he didn't eat good.
Okay. Any recent infection?
No,
I mean, in his bowel or in his in his throat, sorry, any sore throat?
no,
Okay. Did you notice any rash on him? Skin
no,
rash?
no.
Any joint pain he complain with?
Maybe because he can't call doctor. Yes, he complaining of some pain at his limbs.
Okay,
Yeah.
what's his long-lasting disease?
He
Are
has
he
a high
diagnosed?
blood pressure, doctor diagnosed about 5 years ago, and he is taking his medication regularly.
Apart from amlodipine, any other medication he's taking?
No, doctor. No,
Any allergy to any medication?
no,
Any herbal remedies?
no, doctor.
And any allergy to any surgery, sorry,
No,
before? Okay. And apart from this, any weather preference he feel?
no, doctor.
Any
No,
chest pain?
no,
Any short of breath?
no,
Any tummy pain?
no, doctor.
Any change of his bowel habit?
No,
Any change in his water work, color, or amount?
no, nothing, I think.
Does he feel thirsty?
No,
Okay. Any family history in of the same problem?
no, doctor. No problems.
Did he travel abroad recently?
No,
Okay. Does he drive?
no, doctor.
Does he smoke?
Yes.
How many cigarettes per day?
I don't know exactly, doctor, but he smoke a lot.
Okay. And does he drink alcohol?
Before 10 years, he was drinking a lot, but the last 10 years, we moderate this intake, and he now drinking in the limit.
Okay. And you told me he's driving?
No,
Okay, good. Any loss of weight?
no, doctor, we didn't notice that.
Mhm. Okay. Who's supporting him at home?
We are all around him, doctor. I am and my two brothers and my mother.
Okay. Do you need any support?
Thank you, doctor.
Okay. The last question. May I examine him?
Yes, yes, you can.
Okay. So I will look to the surrounding. He's using walking aid, right?
No, but like his son helping him walking.
Helping him.
Yeah.
Okay. While I'm examining him, I will ask you some question. What's his previous job?
He has supermarket, doctor, like he managed it.
Yeah.
Yeah.
And because of this, he didn't go again, right? He's at home now.
He's still going, doctor, but you know that he can manage now.
He cannot, yes.
He forgot a lot of things. He can't account good or
Okay.
calculate the yes.
Yeah,
the
we are
things,
sorry
yeah.
about that. We will help you in this regards.
Yes, will be okay.
So the general look, how is the weight and the build of the patient? He looks
It's
fine.
normal. You look no anything noticed, yeah, from general look.
Okay. Any pallor in the hand? I will start by the hand. Any pallor?
No, but the patient don't give you eye contact, and it is
Confused.
like not confused, but he is looking to the ground and he is not looking to you.
Okay.
Okay.
Any tremors in the hand?
No tremors.
Okay. The power in the hand, any lateralization, both hands?
Normal the power.
I will do pronator drift and Hoffman sign.
No,
Positive,
negative.
negative.
Ah,
Does he have any stroke or mini stroke before?
no, doctor, never.
Okay. Now I will examine the eye,
Yes,
the field. He can follow me. The
yes, he
acuity
can
first.
follow.
The acuity he can read.
Yes, he can.
He can read any ptosis, any change of the eye color.
No,
The eye field. Now I will do the eye field, old field. Any change?
the examiner said no need.
Okay, I will offer fundoscopy.
No need.
No need. Okay, and now I will examine for the cranial nerve. Any asymmetry in the face?
No,
Any neck swelling for thyroid, I mean?
no.
Okay. Can I do H shape? Any diplopia?
The examiner said no need
No need.
because he
I will,
is just he can't cooperate
yeah.
more with you, the patient. Yeah.
Okay. I will check the neck, any neck stiffness.
No neck stiffness.
No neck, okay, I detect the apex in place.
Yes.
Any murmur over the
No.
aortic areas, aortic stenosis,
No.
any regurg.
No.
Okay, now I will ask to examine the back, any heart failure signs.
You mean edema يعني? No.
Yes,
Any crepitation, edema? No.
yes, nothing. He's on Follis?
No.
No Follis. I can ask him to open his mouth and to check he can swallow, any difficult swallowing.
No. No problem.
Nothing. I will examine quickly the tone power reflexes in the hand and in the legs. Any change in the tone?
What you will start by legs or by the hand?
Okay, let's
Upper
start
or
by
lower?
hand. Any rigidity, cogwheel or
By
leg
lower.
bind?
Start by lower. The
Okay,
problem is the gate. So
okay.
you will
Any
start by lower. Okay.
okay. Any
There is
hypertonia,
yes, there is some hypertonia. The power
hypertonia,
is good. Yeah. The power is
reflexes?
good in all movement. Reflexes is slightly in some reflex hyper and normal in some reflex.
Okay. This coordination he can do.
No, he can't.
Okay, and the face in nystagmus. It's important. Sorry.
No, you didn't notice. And also the examiner said you need to examine the eye.
Okay. I asked now the last thing to do, the gait. Can I see his gait?
Yes, you will see like slow shuffling gait, but it is wide gait.
White based, yes. Okay.
Wide.
So I can't do any other like Romberg disc. Okay, the last thing, any sensation affection?
No,
One only,
sensory intact.
fine and deep.
Yes.
Okay. May I
Normal.
know what's the concern, Mr.
I need to know what is problem with my father, doctor. Why this
Yes,
is gait and why he is falling frequently.
yes, I appreciate your concern, Mr. Ahmed. Uh, to diagnose Mr. Hamid, we have to admit him and to run some image, some lab tests, blood tests, and we will update you about the possible diagnosis. Mostly, he has a condition, might be, it's called normal pressure hydrocephalus. Don't bother about the name. It's one of the disease affecting his brain in the elderly people.
So
There
it
is
is
also,
treatable condition, doctor.
I appreciate your concern. It can be controlled, and we have some medicine to do uh, apart from some surgery if needed. According also to our group of doctors, they will see your father, and we will update you in the coming meeting about the possible management plan. You have any other concern?
He can back to his normal life, doctor, or it is he will remain like that.
I'm afraid to say he might be like that because most of this brain disease or nerve disease stay the same affected for a long time. I'm sorry, and I'm afraid to say that. Any other
Well,
concern?
doctor, okay, thank you. Thank you.
Okay, let's go to the examiner question.
Okay, so what is your positive data in this patient?
Yes, I examined, and Mr. Hamid, I took a history from his son. Mr. Hamid, he's 65, hypertensive patient on amlodipine. He has complained of abnormal gait and frequent falls for the last 6 weeks. And the problem started gradually, progressive, together with the cognitive dysfunction. For the last 2 weeks, patient is not fully awake or not fully conscious. Plus, he has some impulsive behavior, aggressive behavior. So,
Mhm.
in the history, I could appreciate history of uh, frequent fall, yes, and incontinence, yes. Another positive finding in the history was urinary incontinence plus unsteadiness.
Okay.
I
So what
couldn't
is
appreciate
possible
any other
diagnosis?
neurological. Yeah.
In the finding in examination,
Yes.
what you find?
On examination, I found he has some rigidity in the legs, reflexes were intact, and some reflexes were intact and the other was affected. Apart from this, I couldn't do the cerebellar examination. He couldn't do the coordination. The gait is wide-based gait, mostly cerebellar or ataxic gait.
Yeah.
So
Okay.
based on this finding, Mr. Hamid might have suggestive features of normal pressure hydrocephalus. Other differential, I can put cerebellar syndrome or Parkinson Parkinson plus syndrome. The last differential will be alcoholic toxicity.
Yes, it can be stroke to the cerebellar.
Yes, cerebellar stroke or cerebellar syndrome,
Yeah.
maybe stroke or
Okay.
hemorrhage. Yes.
Okay. So what your investigation will do?
Yes, started as an acute state. Patient should be managed as ABCD approach. Then after that, I could admit the patient, doing CT urgent for him to rule out any hemorrhage. If no hemorrhage, I will
What you will
do.
find on CT for this patient for your suspicion?
Yes, if I suspect, I will find dilated ventricles, all ventricles in the brain.
Excellent. Okay. What's
And
the
also,
next you will do after CT?
yes, I could also do fundoscopy for papilledema. And I could also think about CSF measurement, pressure, LP, lumbar puncture, through lumbar
LB,
puncture.
yes. Okay.
Yes.
Excellent. Okay. So the management now?
Yeah, under multidisciplinary team approach, including the neurologists and neurosurgery, also geriatric, along with the urology and
Psychology. Okay.
psychology, physiotherapist, rehabilitation, specialized nurse, and GP.
Occupational. Okay.
Occupational therapist, yes.
Okay. And then?
Non-pharmacological education counseling about the disease and the complications. And I could also involve the SOL teams, speech and
You know
language therapy.
definitive treatment for this case?
Yeah, definite treatment of normal pressure hydrocephalus will be frequent drainage or shunting.
Excellent.
And
Okay.
acetazolamide might help for the drainage, they reduce the ACS.
This patient, what's the prognosis?
Since he has dementia and cognitive dysfunction, I think the prognosis is not good. I'm not sure.
It's like Alzheimer or better than?
Yeah, progressive one, yes.
Okay. Any help after doing the shunt?
Occupational therapist can help the patient to cope with his daily activity at home.
Okay. Okay, thank you.
Thank you, Dr. Aisha. Okay, you can comment
Well
now.
done, Doctor. Okay. So this case coming is recently also again in UK. It is every year they bring it once. Before they bringing the patient, but now they bringing a son or surrogate yani with the patient because the patient maybe he can't explain good the condition. So you did well in asking the history, just you missed some points like the blood pressure control, if he is controlled or not.
Yes.
Okay. And if he has any similar condition in the past, because M is one of differential, but he is old age, yes, I know, but if young, you will think MS also. MS, he can come by relapsing, by cerebellar sign only. Yes, by cerebellar only. Also, you will you ask him about the progressive course and the other ataxia, like disturbed speech, the shaking of hands. You ask him also about weakness and headache, and this is good. You can also ask about abnormal movement. This will help also. Okay.
I ask about shakiness, tremors.
But also the seizures you will include.
Okay. Okay.
abnormal movement or shaking or like that. Okay, you will ask if diagnosed by any psychotic problem in the past because some antipsychotic have the same side effect of this problem. Okay, so ask because he has now psychotic problem. So you will ask any psychological problem in the past, any mood problem in the past, has he is on any medication for the mood. Okay, and hallucination important because Lewy body dementia, it's one of Parkinson plus, and it is just has hallucination, visual and auditory
Yes.
hallucination. So we'll ask about. Okay.
Yes, you're right.
About you ask good about forgetfulness and concentration and behavior. This is very good. About waterwork, this is the clue here. He has incontinence. Okay, there is you ask about sensation and joint pain, muscle pain. And also you ask about constitutional symptoms for excluding any meningitis, and this is very important.
Paraneoplastic
For
syndrome as well.
also, yes, and meningitis and paraneoplastic.
Yeah.
For social history, you offer support. This is good. Smoking and alcohol, very important here. This patient concern you also replied good, but a normal pressure hydrocephalus is better prognosis than Alzheimer and makes the patient cognitive symptoms and gait improving after the shunt. And this very there is like they making it as a test for this condition by removing some CSF lumbar puncture, and they will wait till 1 hour. They will see again the gait of the patient and the memory function and the coordination function, and they will find that it is markedly improved. And this patient is candidate for shunt after that. They didn't do shunt for everyone, just this patient with this improved test, they will do shunt because the shunt has 50% problem. You know the problem with shunt?
Yes.
Infection and seizure.
Infection,
Meningitis and seizures.
Infection.
Yes, it is infection, like meningitis and encephalitis and seizures. And this is happening in 50% that doing this procedure. So it is very common, and you need to make sure that the patient will benefit from these procedures. So you will do.
For doing it, yes.
So it is, you will reassure the son if this condition that we suspect, yes, his cognitive function and the gait can improve after this. There is a lot of videos on YouTube. They like making this test like life before the lumbar puncture and after lumbar puncture. It's very different patient. You will see it. Very different patient. You will see the patient gait will improve very much and rapidly moving and no any problem imbalance. And also he can like regain the information. He can calculate some things, and before he can't. It is rapid improvement.
And the control of water work, he can
No,
be
it is
regained?
not. No.
Okay.
This is the signs that not will regain
Okay.
by removing. Maybe because it is also come not early in the problem. It's come late. This condition is ventricle, so you will find that the brain around the ventricle is the most starting point to have problem. Then it will include all if you will not treat the case, or if the treatment not good. Maybe you will make shunt, and also the patient will progress to the terminal.
Yeah, if the
that
compression
he will,
happens,
yes, the dementia will progress and the bradykinesia will progress, and he will end like Alzheimer. Yes, he will end like that. And for the upper limb, in most patient it will be free. You will not find anything. And
okay.
the tremor of Parkinson is very late in this patient. So you will not notice. You missed in examination just you will start by lower limb examination in this patient.
Yes.
And you will ask about the vital sign and the pulse. And you didn't ask. This is important. And you start directly by lower limb because you will not have time. Start by lower limb and the gait first. then you will check the lower limb power and the reflex, because the problem here, the complaint is
Yes, the gate.
unsteady gait. Yes, so you will
Mm.
check the lower limb first, and you will find all the finding in the lower limb, the upper limb and the cranial, all. And these patients, the examiner will not let you to examine the cranial or the eye because no time. So just you will see the gait. It's like wide gait, but it is shuffling, not like drunking exactly, not like cerebellar exactly. They defined it as walking on a boot, like you will be in slow and ataxic gait. Slow and ataxic, and
Yeah,
this is only
mix
found in,
between
yes, it is
Parkinson
only
and
in normal pressure hydrocephalus. Yes, it's very characteristic gait for him. You will check for plantar, you will Babinski sign,
yes,
you missed
reflex.
it. And there is one
Yes,
reflex specific for this condition. I found it. It is gasp reflex. You know the gasp reflex of neonates? They
yeah,
doing
when
it is
yeah,
it is
you hold the hand,
in the
yes,
lower limb. No, you will put make in the feet.
and he will flex all fingers.
Flex all the finger. If you will put your
Okay.
finger steady on the plantar of the
The
feet,
sole.
you will
Yeah.
found his finger, and this is 50% in the patient positive, and this is very characteristic of this condition also. Later it can be in the hand, but if the hand affected in later the disease. Okay, in this patient, the investigation, you make it good. And the treatment also, you offer good. This patient, medical medication is not going on, so you will not tell the patient that he will take some medication. No, any medicine, oral medicine will have, they found help, not acetazolamide, levodopa, not the medication for high intracrine pressure
Yeah, the
benefit
idiopathic.
because he has normal pressure, okay? And
Okay.
not the medication of Parkinson help because it is not
It is not
basal
Parkinson.
ganglia problem.
Degeneration.
Yes.
Yes, yes.
So it is not help any medication till now for this
Only
patient, but it
surgery.
can manage the symptoms. You can give some medication for the rigidity, for the bradykinesia, like Parkinson. You can manage the symptoms, but it's not like treatment for the kid.
Not cure.
Yes. في one other point.
No effect for acetazolamide.
No any
No,
benefit.
only
And they
need
also making
when
it like test. They making it
idiopathic.
like test. They will give levodopa, a challenge test, and it's not helpful to rule out the idiopathic protein. And they will give acetazolamide, and it's not helpful for reducing pressure. And they will measure the lumbar puncture pressure. They will find it normal. Okay. For this patient, no need for fundus, no papilla edema, you're fine. It is normal pressure hydrocephalus. So didn't tell that he may have papilla edema or something. Okay.
No papilla edema at all because
هو
a normal
reflect له ده
pressure.
أثر صح؟
Yes.
أنت جبت عشان تستبعد الثاني
Maybe
صح؟
you will
yes,
exclude.
to rule out meningitis or any
Suspicious nubile
increase,
lesion,
yeah,
meningitis.
increase intraocular pressure. Yes.
Maybe okay. If that is okay. But this patient, he will not have any signs of high intraocular pressure. Okay.
Okay. The CSF, Dr. Aisha, the measurement, it will be normal, right?
Normal, yes. It's very characteristic to be normal.
Less than, I guess, to less than 20.
I don't know the number exactly, but it is
But
normal.
normal
It
pressure.
is normal
Yes.
pressure hydrocephalus.
Normal تقريبا لحد 18 لحد
Yeah.
18
Okay.
18 to 20 I think.
And as you said, they making like lumbar puncture, but
Frequent.
a big amount. يعني. They making a big amount lumbar puncture, and this is characteristic. He will be the patient after 1 hour. You will find that he
Change
improving.
dramatically
Yes,
improve.
improve.
Yes.
Dramatic. Yes. This all thing is about the case, I think here.
And the patient, if they test for the drainage,
Positive, there is ventriculoperitoneal or ventriculopleural, ventricular atrial. Or يعني just it is shunt.
shunting.
Shunt.
Okay.
Yes.
But the most
Just
common
will
is
help in
peritoneal, VB shunt. This is the most common.
peritoneal.
Yes.
Yes.
And the test before shunt, what's called, Dr. Aisha?
lumbar puncture. Yes, large amount CSF
And you will see if
extraction.
he's
Yeah.
improving. Yes, if he's improving,
Yes,
so
after 1 hour. Yeah, after 1 hour.
this is a
They will
mark
wait.
that the patient will get benefit from the
Yes,
shunt.
the hallmark is that you will do
Okay.
the shunt.
Okay. Last question: the difference between incontinence in normal pressure hydrocephalus and incontinence in Parkinson.
Parkinson have incontinence
Later, yes. Later on
later.
in the disease, yes.
overflow incontinence.
No,
Type
and
of
I mean
incontinence is
the
that?
duration, the onset of
Okay, yes,
yeah,
yes.
it started
Oh,
here
The
earlier.
hydrocephalus is very rapid progressive disease.
Yes.
You will
early.
find the patient not like Parkinson, not like dementia. Dementia is slowly progressive. You will find the patient, if not vascular, يعني dementia, if not something vascular. And you can put here in differential also, Dr. Bassem, the
Stroke?
vascular causes. Yes,
Stroke cause, yes.
yes, stroke. You should
But
put
it's
stroke.
still as abnormal wide base gait, I can put cerebellar syndrome.
Yes,
Whatever
it
the
is
reason.
stroke anywhere. يعني because it is upper motor neuron signs also in lower limb, and it is like acute in somehow. يعني if we will say yes, it can be acute course. Yeah, and he has high blood pressure. He is smoker, so you can put it.
Okay.
In this case, the symptoms started when?
6
6
weeks.
weeks.
6 weeks ago. Okay. I think also it's important to ask about trauma in any
Yes.
neurological
Yes.
case.
You're right. And also the mood, any depression, because most of the neurological disease having mood disturbance. So he might be depressed. Most of Parkinson, they are depressed.
Mm.
So
They can give us this case, and they can because it is from surrogate, they can handle it for anything. They can bring a
yes,
Parkinson, but they will
yes,
lead you to the hydrocephalus by history. Because you will not know if he has incontinence and the memory problem,
yes.
you will put
So the
this in
question,
differential.
yeah,
Yeah.
the question will guide you. Which
Yes,
started first,
very
and
important.
yes,
Yes,
exactly.
because these days they lead to, they tend to make like that in cases.
Yes, yes, you're right. Okay, thank you, Dr. Aisha, for the case. Nice case.
Thank you.
And yes, I needed this complex one. And Parkinson also very high yield topic in the exam, Parkinson or Parkinson plus.
Yes,
So whenever
yes, I
we
found
have
that
Parkinson,
in last year that like
yeah,
coming every like
even
2
in the
or
short,
3
yes,
center.
it might
Yeah,
come as short or as long.
communication. Yes, so
Or
communication.
communication,
Yeah,
yes, Parkinson,
yeah.
exactly. Because it's the prevalence of the disease now, it's too
Privilege.
much.
Yes, yes.
Yeah. So any
Irish ولا UK دكتور باسم؟
any
Irish ولا UK؟
any of
فيهم الاثنين.
can come in both.
خلاص.
Any, yes.
It is this case he can bring the patient easily, so he will bring. You will
Yes,
find
and
Parkinson in the street. You will
yes,
find in
because
the relatives.
yes,
Yes, yes,
and
yes.
he's living like a normal person. He's not.
Yes, so it is common. So he will bring, and he will bring surrogate and adjust the case for what he needs.
Yes, but the most important to find in Parkinson is the triad: tremors, bradykinesia, and rigidity. You have to have these 3 symptoms and signs. Plus, you can ask. You have not. You have to rule out the Parkinson plus progressive supranuclear palsy by asking the gaze up and down, and any hallucination for lower body dementia, and any change of blood pressure or impotence or any
Autonomic feature.
autonomic neuropathy. Yes, this for multisystem
Oh,
atrophy.
this patient, we will find the blunt, the Babinski sign positive on one side and equivocal on the other side. If you do, and it is can be absent and it can be positive. like reflexes.
Not
أنت كان دي
specific.
hyperreflexia or
Yes.
normal reflexes?
You mean non-specific? Okay.
No specific. Yeah.
Okay. So the other Parkinson plus, we mentioned 3, right? Lewy body dementia, progressive supranuclear palsy, and
Supranuclear palsy with gaze.
multi-system atrophy
multi-system atrophy.
وsupranuclear palsy.
Yeah.
Multi-system.
فيها جاز
Corticobasal
impaired
disease.
vertical gas.
Yeah. And drug induced. Very important. This for any Parkinson case. Not only
Yes.
to confirm
Antipsychotic, very
Parkinson.
important. Yes.
Exactly. Not only to confirm you have and you must roll out a plus by question, specific question for each one, and you will get the full mark if you roll out the 4 reason, the possible and the commonest reason of for Parkinson plus. Because we see now a lot of patients with Parkinson plus, not only the Parkinson idiopathic. The vascular also one. You have to ask about vascular Parkinson or vascular cause of Parkinson, like recurrent TIA or recurrent stroke.
Yes.
So
other like البوكسين يعني تسأل من كل الحاجات الثانية، مش في causes كثيرة غير
yes,
الفاسكولار والبوكسين ديوز. في حقة البوكسين في واحدات كثيرات كذا كانت نسيته.
but the common. Ask about the common.
هاي أيوة.
And the
لكن
trauma,
برضه
of
ممكن
course. Yes,
استبعادها.
it's trauma you
الدوب
can ask.
بتاعته.
Yes, trauma also one of the possible causes you have to ask about in the history. Yes, you're right. Okay. Any other comment? I think prognosis, okay.
Dr. Aisha, when this patient asks, is it treatable as a concern when surrogate asks, the optimum reply will be?
If in the exam they ask like he will improve, because it's not treatable really. He will improve. Yes, he may improve some after some procedure if we are sure about the diagnosis in my mind.
Yes, if you're stuck with this question,
But it is not it is not treatable. It is will progress also.
yeah, most of geriatric disease progress because it's like degenerative causes and degenerative disease.
لا دكتور بس ما هم مثلا الديمنشيال هنا بيقول لك من التريتابل كوزز بتاعت الديمنشيا.
Yes, it's very important point because he
ما
will
هي زي
said
الزهايمر، ما هي زي الزهايمر. الزهايمر ان تريتابل لكن
just
الديمنشيا
يعني he will ask my father will improve. Just he will say
يعني
yes.
المرض ككل ما
Yes, he
كديمنشيا
will improve.
كجيت ولا كده
But
ككل
should
ما
be also problematic because some patient will not benefit from shunt and some patient not candidate for shunt. Some patient يعني just to be diplomatic. Yes, he can improve. Just this answer. He can improve if the condition we suspect is true. There is some procedure can improve his condition. He can one center he said he can manage his work again. Yes, he can manage after some time. Yeah. He can
Yes.
work good again or he needs permanent help. Yes, he can. There is a possibility he can work again. Not the Parkinson disease. He just need to hear from you. It is not Parkinson's. Because in
Yes.
Parkinson, you never said that. You will never say that.
Yes, exactly. It will not because also remember that it's normal pressure. So normal mean normal. He might live near normal life, but after let's make it like mnemonic, near normal life because of normal pressure hydrograph after the drainage. And the other thing, as Dr. Aisha mentioned, whenever you are not sure about the information, try to escape from the answer, like saying. We have to do some investigation, and after confirming diagnosis, I will update you about this, or I will address your concern. Because maybe it's another condition, or even you don't know the correct answer, you can escape like this. For me, I will do like this. If I'm not sure 100%, I will try to say like that.
But now you
After
are
this.
sure. But the examiner really will wait for your response. So if you are sure, you will reply.
Okay, now I know
And
the
not
answer.
replying by because no promises
Yes.
in medicine, really.
Yes.
So you will say, yes, it can.
Yeah, we can. Yeah, we'll do
Just
our
can.
best.
Yeah.
Yes, we'll do
Yes.
our best to let him back to his normal life. That's
Yes,
it.
yes. This is very good.
Yeah.
Reply.
But
Yes.
we don't know what might happen. He might progress, he might worse, he might improve. But
Just
don't
there is
live.
hope. In these
Yeah.
conditions, there is hope. Like
But take
when they
care
bring
of.
some cancer with hope. They
But
very
take care.
angry from you if you deal with it as miserable in communication. If
No,
he
but
bring
also
for you lymphoma in early stage and
yes.
you make it like drama, he will be angry from you.
Okay,
This like that. Just
but
give the if there is hope, give the patient the hope.
take care from the false hope. It will also deduct your mark.
Yes, yes.
So be balanced between the false hope and the correct hope. Okay. Okay. Any question
والله
there?
دي مشكلة دي، والله دي مشكلة دي. عندي question الديفرنشال diagnosis في التوب normal pressure hydrocephalus خلاص. الأذر شنو؟
I put stroke syndrome, either sorry, cerebellar syndrome, either stroke or stroke as
باركنسون
hemorrhagic
هنا
malfunction.
وموجود والديمنشيا موجود اللي هو عادي ديمنشيا عادية الزهايمر عادي you will put vascular causes you will put and dementia Alzheimer and Parkinson disease you will put
Okay.
and cerebellar syndrome as Dr. يعني cerebellar problem.
Yeah, because it's ataxia and frequent fall.
Yes, no, it will be early in the French. Yes.
Assalamu alaikum, Dr. Basim. Only one question. Actually, well done. And Dr. Aisha, thank you for the case. Good preparations and advice for the case. Can we ask about, I would like to complete my examination by doing a mental health examination.
Yes,
Again,
in
please.
neurological case, you should do that, yes.
Okay.
By, you said for neurological examination and the cranial nerve and the eye examination.
No, I mean to say mental state examinations. I mean to
Mental
confirm
state, yes,
dementia.
very good point.
Yeah.
Very good point. It is mildly affected. The mental here, it will be like
It's
25
at the end, yes.
from
At the
30,
end, mental
not very
47.
affected, yes.
Yeah.
And but
But
the
what-
mood, it is the mood, the one he affected. You will see that this patient affected the mini mental, but because of mood. Yeah.
By mood or it is a triad, doctor, right? It is normal pressure hydrocephalus triad. It is a gait
Yes,
abnormality
it is. There
and
is some
dementia.
dementia, but I said you may be the look of the patient that he have severe dementia, but he really
But
have
it's-
mood problem with the dementia. If you
Yeah,
will
okay.
check, you will find that the dementia not too much, 25, like that.
Yes.
Not
it's
like
more than 24.
Alzheimer. Yeah.
Yeah. Thank you.
The memory, you mean?
Yes. It's a mini mental test.
Mental state examinations, yeah, for
Yes.
dementia.
Yeah, can you repeat this point because I had some disconnection from the net. The mini mental state you have to do or you have to offer it.
She said we can offer. Yes, he can offer.
We offer
And
at the
it
end
is
of
really
examination.
done. They did for any patient of dementia. You should do.
Yes, but I don't know the component of the score. So
You will tell in investigation maybe.
yes.
If he said what you do mini mental, you can mention. It is like not very bad.
Yes,
Yeah,
we can
more than-
I
mention.
tell the patient like that. I tell, yeah. But I think they will not guide you to
We will
this
not ask you, just only yes
point
at the end of the
because
examinations
yes,
only. Yeah.
yes. That is
So
just like
we
very
can
specific
offer
point
to be
for
done
that.
by neurology, yes.
Yes, done by
Assessments.
neurology. Yeah.
Okay. Okay. Thank you, Dr. Aisha. Any other question or comment? Thank you, Dr. Hanaida, for your comments. Thank you,
You're
Dr.
welcome.
Thank you. Okay.
Thank you. And just YouTube the gait of this patient because it is really
Okay.
characteristic.
Please share it to the group, please.
And you can see also the gasp reflex. Is characteristic for this patient. Primitive reflex. Yeah.
Okay, please share it to the WhatsApp group when you finish.
في normal
Okay.
pressure hydrocephalus في primitive reflex.
Yes, it has the gasp reflex characteristic in 50% of patients. You cannot do, but you can do, and it will be good for you.
Okay.
يعني not is to be bus
Thank
or
you.
not bus. Just it is adding to the Babinski sign after it.
Okay.
Which is Dr. Aisha again, the grass?
Yes.
Okay. Any other question? Any comment?
No. For my side, no.
Okay, thank you, doctor. Thank you,
Thank
Dr.
you.
Aisha. Thank you all.
Thank you.
Okay, see you tomorrow, inshallah, with communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
عليكم السلام. Bye-bye.